AMH is not associated with high-grade embryo quality as assessed by day 3 and day 5 morphology. This is presented by Rhea Chattopadhyay. Background: anti-Müllerian hormone is used to determine response to gonadotropic hormone stimulation in patients undergoing controlled ovarian hyperstimulation for IVF and is a biomarker for ovarian reserve. Several studies have demonstrated a correlation between AMH and development of good quality blasts. However, other studies have not shown AMH to be a predictive marker. Objective: the purpose of this study was to determine if there is a correlation between AMH and the quality of day 3 and day 5 embryos in patients undergoing fresh IVF cycles. Methods: all fresh IVF cycles at a single academic center in 2016 were evaluated. Patients with an AMH level documented within 1 year prior to stimulation who proceeded to retrieval were included in our analysis. Patients without AMH levels drawn before stimulation were excluded. Experimental parameters included age, BMI, number of eggs retrieved, number of mature eggs, number of fertilized embryos, also known as 2PN, number of day 3 blasts, and number of day 5 blasts. A morphological grading system was used to determine the quality of day 3 and day 5 embryos. Criteria for high-quality day 3, also known as HQD3 embryos, were 7 to 10 cells present, less than 10% fragmentation, no fragmentation or scattered fragmentation seen. For high-quality day 5 blastocysts, also known as HQD5, criteria were presence of blastocysts that is expanding, fully expanded, or hatching, an inner cell mass that is loosely grouped with several cells or tightly packed with many cells, the trophectoderm described as containing few cells forming loose epithelium or many cells forming a cohesive epithelium, and the absence of necrotic cells. Statistical analysis. Multiple linear regression analysis was performed to assess if embryo quality defined as number HQD3 over number 2PN or number HQD5 over number 2PN is associated with AMH level, controlling for patient's age and BMI. Significance was determined at a p-value of 0.05. Results: 292 cycles met inclusion criteria and were analyzed. Higher AMH levels were associated with significantly younger patients. R-squared was 0.09 with a p-value of less than 0.001, and significantly more oocytes retrieved, R-squared of 0.13 with a p-value of less than 0.001. After controlling for age and BMI, there was no significant relationship between AMH level and embryo quality as defined by the study's parameters for percentage of high-quality day 3 and day 5 embryos. Conclusion: in our study, we did not find AMH to be a predictor of embryo quality. This information is important when counseling patients on the utility of AMH. While AMH levels predict the number of oocytes retrieved during an IVF cycle, it may not predict the quality of embryos, which is an important distinction for patients and clinicians. This study received no financial support. These are my references. Thank you for listening to my presentation.